or also like any kind of bacteria. So for example, we've all experienced episodes of aspiration where you might have been sitting with a lot of people, you might have been talking and laughing while you're eating, and all of a sudden you start coughing uncontrollably. You're coughing. It's so embarrassing. And we say that something has gone down the wrong way. Well, that is what aspiration is. That means that food or drink usually goes down below the level of where our vocal folds sit on our windpipe. And if it goes down below that level, our body has a natural response of coughing. And that's just blowing air from our lungs up through our throat to get that thing out of our lungs. Now, for individuals who have some health issues, especially respiratory health issues like COPD, they might not have the strength, the cough strength to get that stuff up, to get it out of the lungs. And if something sits in our lungs, then there is a risk that our body sees it as a foreign object. Only air is typically in our lungs. And so it can set up an infection around that thing, and it can set up and cause pneumonia. That's what's called aspiration pneumonia. We can also aspirate sometimes when we vomit. So when things are coming up, it can slip down into our lungs. And so we might have heard of aspiration pneumonia in that aspect too. So obviously that's a bad association that can happen around meal times. Dysphagia is just the medical term for trouble swallowing. And trouble swallowing can happen anywhere past the lips. So we could have a hard time getting food off of a fork with our lips and our teeth. Dysphagia can happen once it's in the mouth, which would be considered oral dysphagia. So we might have a hard time chewing things up. We might have a hard time moving it around and getting it to the back of the throat. And then as soon as it passes past the back of our mouth, that's considered pharyngeal. So that's pharyngeal dysphagia. And once it goes into the tube that goes to our stomach, that's esophageal. We can also have esophageal dysphagia. So any trouble swallowing from the point where it touches the lips all the way down to our stomachs. Also, of course, with meal times, malnutrition and dehydration can be a concern. If someone is unable to participate in meal times, that can result in isolation and people, not being able to participate in some of those fun times. Also, meal times can be an opportunity for dependence. So if you are not able to feed yourself, it might be a negative feeling to have to rely on someone else to assist you. And then also poor appetite can happen, which then makes meal times a negative experience. So now let's talk about what is dementia. Dementia, according to the Alzheimer's Association, is a general term for loss of memory, language, problem solving, and other thinking abilities that are so severe that it affects daily life. So dementia is an umbrella term. And so this feature here, this picture is from the Alzheimer's Association, and it always describes dementia as an umbrella. So similarly, we might think about mental health conditions. That if we think of mental health conditions as the umbrella, then the actual diagnoses underneath that might be depression, anxiety, schizophrenia, bipolar. So dementia is the overall arching term. And then we have types or diagnosis that go underneath that. Now, with the different types of dementia, we have different symptoms that are present with each type of dementia. And although when we think about dementia, we think of short-term memory loss, that is not necessarily always the first symptom or the primary symptom. So some people can be diagnosed with dementia, a type of dementia, and not have any problems with short-term memory. So just like I said, different types of dementia have different symptoms, there are some types of dementia that have a more significant impact on eating because the symptoms will impact eating more so than the others. So let's just run through these really quick. Alzheimer's disease is the most common type of dementia. Alzheimer's is the symptoms we see most often are short-term memory loss. So Alzheimer's accounts for anywhere from like 60 to 80% of people with dementia. And so this is why when we think of dementia, we think of short-term memory loss. because the vast majority of people with dementia do have short-term memory loss issues. But if we move down, we have vascular dementia, which is caused by ischemic changes in the brain or blood flow changes. This can be people who have had past strokes or mini strokes, which are called TIAs, transient ischemic attacks. They are at a higher risk of vascular dementia because part of the brain is damaged and it makes thinking difficult. Now, people with vascular dementia will have a lot of different symptoms because it completely relies on where in the brain the damage has occurred, which is what symptoms are shown. Lewy body dementia is caused by these things called Lewy bodies that form in the neurons of our brain. They're proteins. And the most common symptoms for Lewy body dementia are visual hallucinations, REM sleep behavior disorders, and like fluctuations in alertness. So there are days where they're really lucid, moments that they're really lucid, and then moments where they're really confused. This is also very closely associated with Parkinson's disease. And if you have Parkinson's disease-like symptoms along with Lewy body dementia, then that will be a recipe for difficulty swallowing, because people with Parkinson's and Lewy body will often have tremors. They will have difficulty coordinating the movements of like the muscles, and swallowing is one of those things that become difficult. Frontotemporal dementia happens in the frontal and temporal part of the brain, and it often has changes in behavior and personality. So people with this kind of dementia might seem to act differently. They might be really impulsive. We also see on here Huntington's disease. People with Huntington's disease will absolutely have problems chewing and swallowing eventually. That is by definition one of the biggest symptoms. So majority of people with Parkinson's disease and Huntington's disease, actually their cause of death will eventually be aspiration pneumonia. And so based on what type of dementia someone has, we might have different considerations as to how meal times might be affected. Not only do we have different types of dementia, but we have different stages of dementia. And I've done entire trainings just about the stages of dementia. We're not going to spend a lot of time on that here. What I want you to know is that there are several scales that exist to describe the deterioration that happens with dementia. One of the most common might just be early, middle, late dementia, mild, moderate, severe. And we also have the global deterioration scale, the Allen cognitive level scale, and TPS-NOS GEMS. So to kind of describe all of that. But the basic thing is that the functional abilities of people with dementia decline over time. And so as they progress through the stages, they are going to not only need more assistance, but their function and their safety is going to decline over time. So based on what stage they are, they might need more assistance than others. So this all leads us to think, okay, so we know that meal times can be great times or they can be bad times. We know that dementia can cause symptoms that make meal times difficult. Well, how do we know when meal times are becoming difficult? What do we need to look out for? What are the red flags? And this is not an exhaustive list by any means, but these are what I have seen most often. So if we see someone who's eating less, or they're saying that they're not hungry, that might be an indication we need to help. Just like getting up from the table frequently, dropping their utensils. All of these things that are going through here are going to be red flags that we might need to start implementing some interventions that are going to improve their ability to eat either safely or effectively. So I know if you can think about that person with dementia that you have in your mind, are any of these present? Have you seen any of these things happen for that person? All of these things are rooted in more complicated reasons for difficulty with meal times. They're not just being difficult. They're not just being ornery. They're not just playing in their food. They're experiencing neurological changes. So when someone with dementia doesn't eat, we should not assume that it's a choice. Now, let me set up a scenario for you. And I hope that this isn't familiar, but I'm probably 80% sure that you might have heard a situation like this. So let's say we're working in a nursing home. We sit everybody down for a meal and we start serving food. Here's one scenario. A person with dementia gets up before the meal is served, and we say, Mary, sit back down. We haven't eaten yet. And she says, I don't want any. And I go, okay, well, she refused. And I write down on their little list, she refused, right? Or someone is sitting there, we serve them their meal, and they just continue sitting there and they don't do anything. They look at it, they look around, they make no attempts at starting to eat. And so we come over and we say, are you hungry? And they say, no. We say, you don't want it? And they're like, no. So we take their tray away and we write down they refused. Or we put the food in front of them. They move things around, play with their food. Maybe some food gets into their mouth, maybe it doesn't. Maybe they knock it off the table on accident or on purpose, seemingly. All those kind of situations can result in staff or as caregivers making the assumption that that person with dementia made a choice, that they chose that they do not want to eat. And so we mark it down as a refusal, or we chalk it up to, well, they didn't want it, and that's it. What I want you to know is that if someone with dementia demonstrates some of those things, it's not necessarily a choice. And we shouldn't simply start feeding them. The intervention and the answer to this issue is not just to reach over, grab their fork, and to just start helping them eat. That should be our very last thing that we do. There are so many interventions we'll go over today that we can do before we get to feeding them. So how do we know what adaptations to try? We see these red flags, we see that they need help. Now, how do we know what to try? The intervention that we're going to try, the thing that we're going to try are tips and tricks that you might see in some of my videos, you might have heard of or seen online. We have to choose those based on what the problem is. So we know that someone with dementia isn't necessarily making a choice. So why? Why does dementia affect eating? What about dementia causes problems? Once again, I could do an entire training just on this slide alone, but we're going to kind of go over it kind of quickly. But what I want you to know is that dementia is a neurodegenerative disease. That means neuro meaning like neurological. It has to do with the neurons in the brain and how they connect and communicate with each other, all the way either from our brain to our hands or to our mouth, or just thinking in general. And then degenerative, of course, meaning that it's going to get worse over time. And so based on some types or some stages of dementia, we are going to see changes in, first of all, visual spatial abilities. So that is not only seeing things, but understanding where it is in space and what context, like what that means for us. And we'll talk about that a little bit more. We also will see changes in short-term memory. So when we talk about eating, if we don't remember 5 minutes ago, then how are we going to know if we've eaten breakfast? How are we going to know that we've eaten anything at all in the last 20 years? We have no memory of actual sitting down and eating food, right? We have changes in sensation. So not only sensation, like with our fingers, we might have a difficult time feeding ourselves because we have difficulty sensation with our hands, but also taste. We're having difficulty and changes in our taste. We also are going to have changes in procedural memory. So we've all seen those like viral videos of someone with dementia who can play the piano beautifully, even though they might not even remember or recognize their daughter anymore, or they can dance this beautiful dance. And it's one of those things, it's motor memory that just happens. Their body remembers more so than their brain. So procedural memory also, though, is picking up a toothbrush and brushing our teeth. And it's also picking up a fork and feeding ourselves. We have changes in initiation. Initiation just means starting a task. And beside that is sequencing. Sequencing is then doing one step and then the next step and knowing what the next step and the next step. And so if we have changes in initiation and sequencing, then someone with dementia might not realize that as their food is sitting in front of them, that they need to pick up their fork, that's the first step that they need to do. And then the next step is that they need to poke it into the food and then bring it to their mouth. We have changes in communication. So if someone is having difficulty communicating and they're served something they don't like, they don't necessarily have the ability to say, excuse me, I know that you served me this grilled cheese, but I haven't eaten cheese my whole life. I don't like it. Can you get me something else? Instead, they're just going to sit there and say that they're not hungry. We have changes in attention. That's where we see a lot of times people standing up and moving around and getting up and leaving. That's also very closely tied to impulsivity. So being very impulsive and just doing whatever they want and not really thinking about it. Problem solving. So if anything happens, your fork drops on the floor, they don't have the ability to necessarily know that they need to bend down and pick it up, or that once they bend down and pick it up, they shouldn't just put it right back in their mouth. They need to ask for someone else to get it for them. Orientation, which is knowing where you are or what time it is. So if you don't have any awareness of where you are or what time it is, you might not know that it's time to eat or that you're in the dining room. And then motor coordination and strength, which definitely will affect your ability to move food from your plate to your mouth. So with all of those changes that occur, it results in a lot of things that we see as behaviors. So dysmetria here at the top is basically undershooting or overshooting objects that you're reaching for. So if I have dysmetria and I'm going to grab my drink, if I overshoot it, I might pour my drink all over the table. And a caregiver might, look at that and be like, oh, like, are you done? Like, you're making a mess now, right? No, it's a neurological impairment has happened because of the deterioration of the brain. Also, all of these things can result in self-neglect, not having the realization that I need to eat or how to eat. And so it might result in me not eating and left to my own devices, starving. It can result in a poor appetite because I just don't really have the awareness, like I said, of time. Apraxia, which there's two different types of apraxia, which is ideational and ideomotor. Ideomotor is knowing how to use an object. Ideational is knowing, okay, that is a fork, but then they don't really necessarily know how to grab it or how to move it. Paranoia, fear, and confusion. Can you imagine just being plopped down in a random room, not knowing who people are, or where you are, and you keep trying to get up because you're scared, and someone keeps pushing you down and saying, no, you need to eat, and they're giving you this food you've never seen. It can cause some confusion. It can cause these paranoias that they're trying to poison me, right? Aphasia, which is a communication deficit, not being able to find the words that we want to say. Inability to follow directions. We might say, sit down, you need to eat, but they don't know how to do that. The list goes on and on. So we'll keep moving, but we have to be able to identify what the problem is to know what the intervention is going to be. So how do we know what works? Here's the second thing. How do we know what works? Well, we can try all these interventions, but before we ever try the first one, we need to figure out how we're going to know if it works or not. And so we have to consider what our goal is. So before we get to the interventions, we want to talk about our goals. And many of you I know might be social workers. So you have these conversations with families pretty frequently. You need to figure out what is like the goal for this family. Is it comfort measures? Is it that they want them to be as safe as possible? So some goals that might be there for someone with dementia is, do we have a goal that someone's going to eat 2,000 calories every day? Maybe for someone who has weight loss, that's what we want. Someone who wanders a lot and burns a lot of calories. Our goal might be that they get 2,000 calories. Our goal might be that they need to feed themselves independently. So someone maybe who has had a stroke, who's just now relearning how to movement in their right arm. Our goal might be, I don't care how much they eat. I just want them to be able to eat independently. It might be that someone has Huntington's disease and they are choking. They're having concerns for aspiration. So our goal might be that I don't care how much they eat or if they eat independently. I just want them to eat as safely as possible with a low risk of aspiration. I don't care about any of that. I just want them to be able to eat their favorite foods. right? That's a lot of times what we land on in hospice care or palliative. Maybe this person has a feeding tube. We don't necessarily, they're not going to be eating. We just want them to, at meal times, to be able to sit with family and have conversation. Maybe our goal is we just don't want them to feel hungry or thirsty. A lot of families have concerns about that. Maybe we just want them to, they can't participate in conversation. We just want them to be present during meal times. Or maybe they have diabetes, and the only goal we have is that they avoid hypo or hyperglycemia, which is low or too high of blood sugar. So we have to determine what the problem is and then what our goals are before we ever start an intervention. And this is really where we mess up a lot of times, because we might see all these really cool tricks and all these really cool tips, and we start applying them to people without taking the second to think, wait a minute, what's the problem? And how do I know if it's going to work? What are my goals? Okay, so once we determine the problem and the goal, now we can start adapting. So this is where we're going to land for the rest of our time here, is I'm just going to talk you through a lot of adaptations and interventions I would love for you to be familiar with and comfortable with, so that you can help guide some of these challenging meal times. All right. So a lot, like the structure of my interventions that I'll be providing to you today will be based on this study by Murphy, Holmes, and Brooks. And so they really try to make a conceptual model for nutritional care. So what are the aspects of care when it comes to meals? And you'll see this little diagram on the side. We have consistency of care that it's going to kind of follow along here. So number one is person-centered nutritional care. We're going to talk about person-centered care in my next slide. And we'll talk about all of these and more in length, but we also want to consider what's the availability of the food and drink, what are the tools, the resources, and the environment. There are a lot of interventions we can apply in that space. What's the individual with dementia's relationship to others while they're eating or drinking? What is their participation in the food process and eating, and then in activities in general? What's the consistency of care? How do we know that we are all on the same team and we're all doing the same thing? And then what kind of information are we providing to caregivers in general? So let's kind of go through those one at a time. So for person-centered care, this is a concept that has been around for a long time when it comes to people with dementia. And so Brooker kind of broke this down in 4 different components. So when it comes to someone with dementia, this is the broad like 10,000 feet version. I always like to think big picture first, and then let's get down to very specifics. So big picture, we need to make sure that we are valuing and respecting people with dementia and those that care for them. Now, we might fall into those that care for them field, but we never want to forget the person with dementia as well. We don't want to just recommend things based on convenience of the caregivers if it has a detrimental effect for someone with dementia. So we got to value both of those. We need to treat individuals with dementia as individuals with unique needs, right? Like I said, if you might feel like people with dementia, but you know individuals with dementia and what worked for them. And we can make good guesses based on our experience, but we have to consider the unique needs of each individual. We want to see the world from the perspective of the person with dementia. That is something that I really struggle with, like trying to figure out, is that something you can teach people? I'm not sure. Sometimes I definitely feel like I can, and then other times I don't think that some people are capable of it. But seeing the world from the perspective of someone with dementia is absolutely essential. And I'll give you, especially when we talk about motivations, we'll talk about that a little bit more. And then also creating a positive social environment with a person with dementia. Socialization can also can be underrated a lot of times. Like we think that because someone with dementia is confused, or they're not able to communicate, or they don't recognize anybody, that they don't have socialization needs, but they absolutely do. All right, so let's get down to it. Here's some specifics. We're zooming in. We can make adaptations to the texture and consistency of the food and drink items itself. Now, we do this a lot as speech language pathologists. This is my realm. When I put my SLP hat on, this is what I do. So dysphagia, if you remember, that is a problem with swallowing. It's a common problem for older people, not just people with dementia, but people that are older in general. Just as like as we get old, sometimes our arms and legs can get weak. Just like that, the muscles in our throat can get weak also, which then impairs the timing that needs to be so precise for safety in swallowing. So a lot of times when we see individuals with difficulty with dysphagia, we will modify their food or drink. And that has been happening for years and years and years. But most recently, and if you are in the speech therapy world, it is being shaken up right now because there's a lot of, in the last 5 years even, there's been a lot of research done that like maybe the modifications that we're making with food and drink aren't actually keeping people as safe as we think that it was. So a systematic review revealed that people with unmodified diets and liquids, that more than half of them will aspirate. Even if we do a modified barium swallow, which is an X-ray, and we watch exactly what food and drink is going down the right way, and we make specific modifications of what should be, even when we do everything right, they're finding that more than half of people will still aspirate. And that people who are on modified, especially drinks, they do not maintain their daily fluid requirement, which then results in dehydration. So it's like, what's better, being not aspirating or being dehydrated? So in the past, diet levels prior to 2019, you have heard things like regular, mechanical, soft, and puree. Those are the 3 diet levels for food. Regular is regular, just like it sounds. Puree is like baby food. And mechanical soft was somewhere in the middle, basically where if you take a back of a fork and you push down, it will smush through the food. So that was the diet levels for food before 2019. And for liquids, there was thin, nectar thick, honey thick, and then pudding thick. But after 2019, there has been the International Dysphagia Diet Standardization Initiative happened. And so they now have this model, which is international. So you can, someone who is being treated in Lexington, Kentucky, and someone who is being treated in Shanghai, China, they are being given the same diet recommendations based from a 0 to a 7-point scale. So once again, that could be an entire training all in of itself, but just be aware that it's no longer regular mechanical soft puree. It's regular, easy to chew, soft and bite-sized, minced and moist, pureed, and then liquidized for food. And then for drinks, it's thin, slightly thick, mildly thick, moderately thick, extremely thick. And there are very specific measurements for each of those diet levels. So that's one way that we can change the meal times to make them safer. Now, we can also provide feeding assistance, which I said should be the last thing that we do. And there are initiation prompts that we can give. So just helping them get started, hand over hand, hand under hand. And then there's total assistance. So I'm going to play this video for you. I hope that you can hear it. Let me make one modification before I try. I'm going to, all right, let me see if this, tell me if it, okay. Can someone tell me in the chat if you can hear that? I played it for a few seconds.
No, we can't hear it.
Okay. Okay. Well, I think because the muting is a little bit different, I'm just going to play it and then I'm going to narrate it. Okay. Because that's what I'm doing basically anyway. So I'm showing things that you can do to modify the diets.
The least amount of assistance is just handing them their spoon and telling them to start. That might be all they need. Next, you might have to load their spoon and then put it in their hand with a natural grasp. Don't put it in their hand in an awkward way that they wouldn't normally feed themselves, like this. The next level of assistance is hand over hand. This is where we surround our hand over top of theirs and assist them in moving the food from the bowl all the way to their mouth. The next level of assistance would be hand under hand. That's where we place their hand over top of ours and we do most of the work. This still allows their body to know that something is moving towards their face. If we have to totally feed them, avoid this situation by moving slow and making sure they see it before it comes to their face.
Okay. So was showing the different levels of assistance that we can provide, from the least amount of assistance to the most amount of assistance. So all of these kind of the difference in hand over hand, hand under hand, even though that someone might need feeding assistance, that doesn't necessarily we need to feed them, right? It doesn't mean we have to feed them. There are many levels that we can do before we get to just totally feeding them to allow them to participate. All right, so now we're going to talk about adaptive prompting, which is very similar to what I just talked about, but a study on prompting, cueing, and behavior guidance resulted in longer meal times, but self-feeding increased. So if we can prompt and cue, which basically just means giving verbal, tactile, and visual cues. So verbal is me saying something, tactile is me touching them, and visual is me showing them. So examples of some of these cues that we can give will be verbal cues to get them started eating. That might sound like, okay, Mary, go ahead and start eating. Something very simple like that. Could be a visual cue of them watching other people eat and seeing other people putting food in their mouth like this, and then like catching on like, oh, that's something I should be doing. So that's a visual cue. A tactile cue might be gentle touches to their shoulder. So we see when someone starts to get up a lot, we just kind of tap them on the shoulder and let them know, hey, stay seated. And then praying or toasting to begin the meal. Some people will sit and not eat at all. And it could be that they're waiting for someone to bless the food. Or it could be that they, at a nursing home, they're sitting with a bunch of people. They think they're at a party and they're waiting for the toast before they start eating or drinking. So we have to think about those kind of things for individuals with dementia. And all of these cues and prompts can be faded. And so can a feeding for like assistance with feeding. And that just basically means that we can start off strong and then pull back. So we might have to help them hand under hand, put food in their mouth. And then we do a lighter touch with them. And then we pull back our hand altogether. And a lot of times they'll continue eating without assistance at all. So it can fade over time. We can also adapt the equipment that they're using. So I just wanted to show you some examples. The first here is called nosy cups. And these cups, so if I have a cup right here, if the drink is low or if my posture is poor, I can't get the drink into my mouth because the top of this cup is hitting the bridge of my nose. And so nosy cups have it cut out. So the cut out portion goes up towards their nose, and it allows us a higher degree of an angle there so we can get food or drinks into their mouth a little bit easier. We can do built up utensils that look like this. So that's for people who might have fine motor deficits. Built up utensils can either be lightweight or they can be heavy. Heavy utensils are good for people with Parkinson's who might have tremors. That heaviness helps to kind of weigh them down and steady them out. Trays and tables can help people get in better position for eating. Sometimes, especially if someone is eating on a couch or something, they might be leaning over on a nightstand beside the bed or an end table. If we can get them a good, nice tray that puts it in front of them, they're going to be more likely to eat and have better outcomes. We can also have rimmed plates, for example. There are bowls like this, and there are also some that are divided. But basically, this is for people who maybe can only use one hand while they eat. And so as they're scooping, they might be chasing things off the side of their plate or off their plate. And so if it has that rim, then they can kind of scoop it a little bit easier. We can also make things smaller. So we can use little cocktail forks. We use this a lot of times when individuals are eating way too much and way too fast. So people with impulsivity, a lot of times people with frontotemporal dementia might do this. And so they eat way too fast, way too much. So if we make their utensils smaller, then it allows them to still eat independently, but it's just it's giving them their body time to get things swallowed before the next bite. We also might see, especially some little old ladies, a lot of times we serve them a big plate of food and they're so overwhelmed and they think that they can't eat it, so they don't even start. But if we take that same food and scrape a little bit of it into a small bowl or onto a small plate, and we just put that in front of them, they'll clean the plate. So then we take that plate back, we refill it, we wait about 3 or 5 minutes, and then we present it again. Short-term memory loss, they don't remember that they've already eaten, so they eat a lot more. And then non-slip surfaces, that stuff is called dicem, and it can be put underneath plates or bowls if they move around a lot when people are trying to eat. We also need to consider like what is motivating to someone with dementia. So if they're not wanting to eat, then what might motivate them to eat? Here's an example. I made a video about this that went viral, and McDonald's actually reached out to me about it. But I talked about using a McDonald's bag. Like I know my grandparents loved Burger King, like they loved it and they ate it all the time. And so if my grandmother didn't want to eat food, I could put whatever food. I could put meatloaf down into a Burger King bag and she would eat it up because it's motivating. That seeing that bag is like, oh, I want that. Or putting it in a cup of a preferred drink that they like, whether it be, I think our generation will probably be Starbucks. They'll be putting Ensures and Starbucks cups and we will drink it right up, right? So presenting it in a way that's motivating. Also, for some of our individuals with dementia who are very thrifty, they love to coupon, maybe we give them a coupon for a free sandwich. And then they're going to be more motivated to eat that sandwich because it was free. So they hand you their coupon and we hand them their sandwich. That's one way we can be creative. And then another way is just presenting it. So let's say someone loves sweets, but they're diabetic and they can't have that all the time. So we might puree a bunch of strawberries and some protein powder, and we put Greek yogurt and all the good stuff, but then we put it in a milkshake glass like this, top it with whipped cream, do a fancy little straw, and they think that they're having just the most decadent, treat. So figuring out what's motivating. We can adapt the environment. So a lot of times we need to consider lighting because visual changes happen with dementia. We need to make sure that where they're sitting and where they're eating is well lit. We also need to have contrast. We hear a lot about using red plates for people with dementia, and that's usually good because it's a contrast to the table wherever they're sitting. But we also need to make sure that we're contrasting the food to the plate. So if we were to be providing them with cherries or watermelon, we might not want to put that on a red plate because that's just going to blend in. So contrast is not just about getting a red plate, it's about making sure that it looks different from the surface it's on. And then sound. I worked most recently in a nursing home who loved to blare music in the dining room, and it was causing a lot of agitation and just distraction. And so I would always come in. We want to probably avoid a lot of music with words and talking, like sound like that, but just some good soothing background music might be good, but for some people, even that might be too overstimulating. So we have to consider that. We also want to consider what direction they're facing. I do this personally with myself. If my husband and I are going out on like a date night and we go to a restaurant and I want to make sure that I can focus on him and like have good conversation, then I'm going to specifically seat myself with my back to the restaurant. So in this picture, someone who's sitting with their back to the wall versus across the table where they're then sitting with their back to the rest of the room, that's going to have a very different experience. So there are some people with dementia that I specifically recommend to be facing, looking at a wall rather than the rest of the facility because their attention is so poor, they get way too distracted. We also need to consider context. So this lady in this picture is sitting in bed and eating, and that might be wonderful for a lot of people, but sitting in bed and eating might be confusing to a generation of people or a specific person who never grew up eating in bed. So you bring them food in bed, they don't know what to do with it. The context tells them this is not a time for eating. And so that might be why they don't eat. And then also we just need to think about simplifying the environment. We don't need to hand them this whole setup here in this picture of tons of things to choose from. We need to remove sometimes even just centerpieces from tables if that can be distracting. We want to adapt socialization. So family style meals have been shown to facilitate mimicry, which is what I talked about earlier, where someone sees someone else eating and so they're more apt to eat themselves. It also highlights that long-term memory that they often have spared long into the disease. They still remember sitting down with their family when they were younger. It also, of course, strengthens socialization and participation. And a study kind of, reflected this, that family style meals result in modest increases in mealtime participation for people with dementia, but the staff training is needed to facilitate that and to kind of prompt them and praise them for participating in meals. We've also seen that Montessori-based activities, which Montessori is most commonly related to children. This was created by Maria Montessori over 100 years ago. But these activities basically just focus on the individual. So a good example of my Montessori task might be cleaning eyeglasses. So that's something that I have people do in facilities a lot of times. We'll have a lost and found drawer of glasses that we don't know who they belong to. And so I might ask someone, hey, do you mind to help me out with something? Here are these glasses, they're really dirty. Could you help me clean them? And so that's a very, that focuses on their ability. They might not be able to do much, but they can certainly do that. That definitely taps into their long-term memory. That's something that is a very motor memory kind of thing. They feel like they're helping. And so if we have someone participate in those kind of Montessori-based activities, evidence is showing that it has a positive impact on their eating behaviors. It might not improve their cognition, but it helps them to stay engaging in things on a table and looking like during meal times. And mealtime itself can be an activity. So we can have someone participate in preparation of a meal or cleaning up after a meal. That has shown to improve the intake. And incorporating themes like, let's have a Hawaii day and we're going to have, pork sandwiches and pineapple, so incorporating activities into meals during mealtimes and outside of mealtimes can really help. We also want to make sure that our staff and our caregivers are trained. So having a training program has shown evidence that will increase eating time and decrease feeding difficulty. So we need to be training people about all the things we talked about today: types of dementia, stages of dementia, neurological underlying impairments, things like dysmetria and ideational apraxia. People need to know what that means so we can identify it as what it is rather than, well, grandma doesn't want to eat, right? So whose job is it to put these adaptations into place? Like I said before, this is going to be a collaborative effort, but the speech language pathologist is going to be in charge of making diet modifications to texture and consistency. An occupational therapist is mostly involved in getting food from the table to the mouth, so self-feeding. Now, SLPs and OTs a lot of times collaborate with self-feeding because there are a lot of swallowing considerations that need to happen. But those two therapists will be really, really helpful to help problem solve any kind of mealtime self-feeding issues. A registered dietitian is going to make recommendations for what is the therapeutic diet. So whether someone needs to be on a consistent carb diet or a renal diet or a heart diet or fluid restriction, right? A physician is going to be the person that's going to look at the whole medical picture and make recommendations. Family caregivers can put these adaptations into place. They know their loved ones better than anybody. But honestly, you can. Whoever you are, if you're a social worker, if you're a family caregiver, whoever you are, we can all work together in making sure that these adaptations are in place. To have the best outcome, though, we need to have all these people involved. So what if they still won't eat? So we have identified the problem. We know what our goal is. We've done all these interventions and they're still not going to eat. Well, here's the deal. Individuals with dementia, when they get to the later stages of dementia, so I always go by the global deterioration scale, but if individuals are in stage 6 or 7, the most severe stages, they are in their end of life. And families need to understand that. That's where training comes into. That families need to know that at the end of life, at those final stages, there are going to need to be decisions made based on the course of dementia and, their goals for that person. And as a social worker, as many of you might be, it's going to be really important that you are part of that conversation, because we know that a loss of appetite and decreased weight is very common in progressed dementia. Even when we make all the right supplements and diet modifications, we can do everything right and they're still going to eat less just because of the nature of the disease. We also know that tube feeding and IV hydration is often not recommended because this is terminal and there is no chance for improvement. Tube feeding and IV hydration a lot of times just kind of draw out the dying process. Symptoms can be, like helped if they're thirsty, if they have dry mouths, we can do oral care. But we just need to understand that that is going to be a possibility. All right. So I hate to end on that down note, but it's reality, right? We have all of these things that we need to consider. So in this time, you can write some questions in the chat if you have any for me, and Brooke will share them with me. But I really appreciate your time. And I want you just to leave here knowing that individuals with dementia, although no, we cannot cure them, and no, we cannot necessarily even reverse anything. What we can do is we can improve their quality of life. We can make them as independent as possible. And, people with dementia often will not have, memory of things that happened in the last 24 hours or the last week or maybe the last 5 years, for example. But they also don't necessarily have the worries of the future. That's what disorientation and short-term memory loss can do to a person. And although that sounds bleak, know that that means that individuals with dementia very much live in the moment. And if we can make every moment as joyful and as pleasant and pleasurable as we possibly can, then that is literally the whole world to them. And so there's absolutely room for that, especially during meal times.
Wonderful. Thank you so much, Adria. This has been so informative and really enjoyable to hear from you. So I have a few questions here. One was from Mr. Ranjuna. He's asking, can you give some examples of what comfort feeding is? Yeah, so as a speech language pathologist, I come across this a lot. Maybe that someone is having difficulty swallowing and we do all the assessments that we need to, and we say, okay, this person is safest on a puree diet with honey thick liquids. So that means that they're going to basically, all their food is going to be pureed like baby food, and their drinks are going to be the consistency of honey. And so I tell this to the family member, and we have this conversation with the doctor, and the family member says, listen, dad is 96 years old. We know that he has dementia. He is not going to, he's not going to enjoy that diet. He's not going to enjoy baby food. He's not going to enjoy those liquids. We're more worried about him just not drinking at all. So what I want is I want my dad to eat whatever he wants. And I want him to be able to drink whatever he wants to. And I know that that might result in his death, but knowing his situation and where he is, we just want him to have the best quality of life until the end. And so a comfort feeding, or comfort food, or a comfort diet, is basically whatever the family desires that is against medical recommendations for safety. And as a speech language pathologist myself, I completely respect that. And families have every right to make that decision. And I say families because usually we're talking about someone with dementia who has progressed to the point that they can't make that decision for themselves. But a comfort feeding or a diet is basically that. It's just asking them or allowing them to eat or drink whatever they want, knowing the risks of what could happen. Okay, thank you. Another question is, where would you recommend purchasing adaptive equipment items?
Yeah, so Amazon is a great place. Most of the time, insurance or Medicare doesn't typically cover those kind of things, but they're typically less than $25. A lot of the things that I put on my on that screen were very cheap. And so those can be purchased on Amazon. They can be purchased in medical supply places. So if you have a local DME company that has like wheelchairs and walkers and things like that, a lot of times they will have adaptive utensils and plates and things like that. So you can also check those places. But I also recommend, especially if there's a swallowing problem, kind of running those recommendations by a speech language pathologist to make sure it's not going to increase the risk of getting choked or something like that, especially with cups. That's usually a problem.
Yeah. Okay. Good deal. Another question from Ms. Deborah. She says, do you have any recommendations for long-term personal care programs in Baton Rouge? Ms. Deborah, I'm not sure exactly what you're asking for, if you're looking for a long-term care facility or programs like with a therapist, but I do have your email, so I can reach out to you directly. I'm not sure exactly what your goal is. So maybe if you wanted to elaborate a little bit in the chat, if not, I'm happy to provide whatever information to you after a little bit more context. Okay. Any other questions from anybody? We're at the last couple minutes of our presentation here. We had someone that said, great presentation. Thank you, Adria, which I agree.
Oh, you're welcome. This is a lot of fun for me, so I appreciate the opportunity.
I have a question.
Yeah.
So, okay, Ms. Deborah, I can reach out to you individually and I can talk to you about that. So I have a question. So if your loved one lives in a facility or, not with me, but I know that she would need some of these adaptive techniques, how would you recommend to go about that for me to bring that to a facility or to another person that cares for my loved one?
That's a great question. Therapy, I think it'd be the best avenue to go through, an occupational and a speech language pathologist, because those individuals can not only make specific recommendations on exactly what is best for your loved one with dementia, but they can be behind the doors of the facility. They can be in charge of that training that we talked about, that they can talk to caregivers and say, hey, this is the nosy cup that we recommend, and this is how to use it, and this is why it's important. And so if you are just trying to go in and say, hey, I bought this for my mom, I think she should use it, and you're having to try to get every shift and every person, it's going to be really difficult. So an occupational therapist and a speech language pathologist would be your best bet. And the way that you get a referral for that, I would say like 90% of especially skilled nursing facilities have those kinds of therapy. So basically, I would just talk to the nurse that is with, over your loved one that you're familiar with or whatever, and just ask, hey, can I get a referral? So you can just ask a referral. That's a good word for occupational and speech language pathology or speech therapy. Same thing. Because I think my mom could really benefit from some, interventions during meals. And then they can facilitate that. And my recommendation always is to call and follow up to make sure those recommendations are followed through with. But that would be your best bet, because also, especially with Medicare, therapy is covered under insurance. So it's not going to cost you anything for those kind of services. You might have to pay out of pocket for the actual cups or plates or whatever. But inside a facility, all of those things have to have orders. It has to have a doctor order to do that kind of adaptation, anything that's different from what everyone else gets. And so it's really important that we get that collaboration with nursing and therapy, and they will facilitate getting the doctor order to make sure that everything is documented and it's recommended correctly.
Perfect. Thank you so much. Okay, well, that concludes our presentation today. I will be sending out a follow-up email that will have Adria's contact information in it, and then also an evaluation for the presentation. If you're a social worker looking for the CEU certificate, you have to fill out the evaluation, and then that's how I'll know who to send it to. But thank y'all so much for participating today. Thank you so much, Adria. Hope y'all all have a great rest of your Tuesday.
All right, thank you.
Thank you.